minute.
You will like to see another important face?
Yes.
Yeah, why not? Why not? Why
Yeah.
not?
I have Lalit Verma with me.
Arey, sir, it's a privilege.
Oh, wow.
Privilege, sir.
So we are live.
Our honor.
It's a privilege, sir. Please do join.
Wonderful.
Hi,
Sir,
Prashant.
sir.
क्या हाल है?
Good evening,
Hi.
sir.
Welcome, welcome.
Good evening.
Hi, Anaga, how are you?
First class, sir. Good
सब
evening.
बढ़िया? So I'm so happy with this ARC team actually. I just I just entered his house and
Wow.
I was typing for Prashant. Prashant, तुमने मैसेज पढ़ा हमारा?
सर अभी बस ये कन्वर्सेशन चालू था इसलिए.
So please वो पढ़ के सबको सुना देना यार. एक important है.
नहीं
Please
नहीं.
read that and tell everybody.
Sir, you will be speaking for 2 minutes once we initiate the program. It's our
Okay.
fortune that you are with us. Just hold on for a
Mhm.
while. We are just initiating the program. Sunil
Okay.
ji, what's the status?
Yeah, live, sir.
We are live? Okay. So, good evening, postgraduates, and happy Guru Purnimas to all the mentors and all the teachers who are with us today. Welcome to this 100th episode of All India Postgraduate Teaching Program, which is an initiative from Academic and Research Committee of All India Ophthalmological Society. We boast of this PG program to be a bit different compared to other teaching programs because we try to cover the topics which are not covered in other postgraduate teaching programs. For example, case presentations, journal clubs, OSCEs, and didactics very rarely on topics which are not comprehensively available in textbook. Today, it's a strange coincidence, a very privileged coincidence. Today is the 100th episode of our PG teaching program. It was 2 years back when I became chairman ARC and the new team of ARC came. The then president, Dr. Harbansh Lal sir, asked me that as a All India Ophthalmological Society, we do not have any postgraduate teaching program. And rather he nudged me, rather he forced me. And today we are into 100th episode. We are very lucky to have Dr. Harbansh Lal sir, who will be addressing the postgraduates after a short while. Thank you, Harbansh Lal sir, for initiating this program and making it so hit. Not just boasting, but we are so proud to share that the program has a coverage or the viewership which varies from 2,500 to 4,000 in a week after every episode. And really thankful, Dr. Harbansh Lal sir, for this initiative. Also, we are proud to have our AIOS president, Dr. Partha Bishwas, a dear friend of mine. He was a co-fellow of mine in our fellowship days. Thank you, Partha sir, for being with us for this particular special event today. Now, without much ado, can I request Dr. Partha Bishwas, President, All India Ophthalmological Society, to address the postgraduates as well as the mentor within a short while.
Thank you very much, Prashant, and thank you for this wonderful opportunity. What a coincidence that it is Guru Purnima, and one of, not one, but so many of my gurus are present on the screen right here. So, right from Harbansh Lal, sir, you'll have to move the camera to Dr. Lalit Verma also. Sir, move your camera. Harbansh Lal, sir, move the camera to Dr. Lalit Verma as well. So, he is my guru as well. And let me tell you, my entry into as chairman ARC 12 years ago was on the initiation by Dr. Lalit Verma. He said, you have to go in for this post and you have to do well in this post. So
Hello.
it was my first entry into the AIOS, the leadership.
Hello, can you hear
Yeah. Am I audible?
Yeah. Partha, you are audible.
Okay. So really thanks to the whole team that has taken ARC by leaps and bounds and to a different level altogether. We are really proud of the ARC being a very, very strong team at the AIOS, and Dr. Prashant and the team are doing extremely well, spreading and giving so much to the postgraduates and to the fellows that possibly that huge amount is there to be consumed as well. So it's always a challenge that you have to consume what you're giving. And if you can consume that, that's a huge, huge thing for all of us. Guru Purnima, I think this is a very important occasion for all of us. and especially from India, Hindus, Jains, Buddhists, everybody celebrates Guru Purnima, and the world over, in fact. So Guru is Guru, and whatever you learn from the Guru is something that you need to pass on to your disciples or to your students as well. So it was Guru Purnima, and it is also called Vyas Purnima. And Vyasdev was the one who, can it be a quiz? What did Vyasdev do, and why is it called Guru Purnima? Well, Vyasdev actually wrote the Mahabharata and also was the collaborator of the Vedas. So from Vyasdev, Guru Purnima is what started. So let's have this episode, a phenomenal episode. Let's learn from each other. And I wish all the postgraduates a huge success in their careers and happy learning today.
Thank you, Dr. Partha. Can I request our past president, Dr. Harbansh Lal sir, to address the postgraduates? He was the person who nudged this team of ARC to do this particular thing. So please, sir, a word from you. How do you look at it, at the effort which ARC has taken over?
Yeah, hello.
Yes, sir, we can hear you. Hello. Sir, we can't hear you.
Voice is
Sir, we can't hear you. Harbansh Lal sir.
Sir, I think two devices are open at your end.
And there are so many private medical colleges, and the medical colleges where the faculty is not sufficient. Just there are 2 or 3 faculties for them to finish off the clinical work. Too much and really too much, and it's very difficult for them. Can you hear me?
No, sir.
Am I audible?
Yeah, now it is better. Now it is better. 2 devices were open, sir, I think.
Sunil ji, can you guide?
Yeah, I'm just checking, sir.
I think
Dr. Harbansh's this thing is muted, frozen. Hello.
Maybe some net issue also.
Hello.
yeah.
We can hear you now.
Hello.
Yes, sir.
Am I better now?
Yes, better.
Is it better now?
Yes.
Yes, sir.
Okay, if it is better, so my idea was all our GC members.
Sir, there is an echo.
Actually, sir, 1
Sir,
minute.
sir,
And
There are 2 devices which are open, I think, in the same room. I think they are hindering each other.
Lalit sir, और आपको you have to make a distance.
ललित ने ऑफ कर दिया वैसे.
हाँ जी.
अच्छा, अब ललित का डिवाइस ऑफ है. Is it better now?
Yes, sir.
Yes, sir. Carry on.
So I wanted all my GC members to have some extra responsibilities, and we started a lot of new things. But I think the Prashant Bhavan was the one person. As soon as I gave the idea, within a week he implemented, and not only implemented, actually found out the best of the faculty across the country. I mean, the type of the teachers which most of us will not even be able to approach them. I will not be able to listen to them, and really designed this program very well. And you can judge from this that the popularity of the program, initially 8,000, 10,000, I mean, over the period of time, the worship runs into the lakhs of them. So I think this is, and whole team has really cooperated very well. And I'm sure that the PGs are benefit from them. And only at the time of the Guru Purnima, I'll definitely, when I was the president of the Delhi Optometrical Society, I had written one article that if as a teacher, if you are not teaching your students, then somebody is not teaching your son and daughter somewhere else. So as a teacher, it is our duty to teach our students, irrespective of the type of the student, whether they are good or bad, whether they respect you or they don't respect you. But my request to the student was that you cannot give anything to your teachers. You can only give the respect. no student can give anything. I mean, we are not, no teacher respect to the teacher. If you give a respect to the teacher, then the teachers won't have the motivation to teach you. So I request all the PGs across the country that nothing else is needed. Do respect and regard. I find sometimes some of the students we should take it to our heart. We should do our job. But I do request the postgraduates to do respect the teachers and from wherever they learn in their life. With that, thank you very much. And I hope this program continues for next few more years and most of the PGs will be benefiting. And now I'll hand over my mobile to Lalit Verma.
Request Dr. Lalit Verma sir to guide the students forever.
No, I think let me at the outset congratulate the chairman ARC, Prashant.
Side
who
setting.
I am so proud that he has taken ARC to a different level now. In fact, this is what I was talking in the last meeting at Chennai, and he actually after Partha Biswas, who did a lot of work as chairman ARC in his 2 terms, Prashant has really taken to a higher level. And I just wrote on his personal SMS, Prashant, what did I write? What I wrote there was congratulations on finishing a century, the master blaster of ARC India. That's what I wrote. And this came from my heart, actually, Partho. I just came to know that, I was not here when I wrote this. I was, driving way back. So I congratulate the entire ARC team and hats off to the current president, Partha Biswas. The reason is, apart from being president today, he was the chairman ARC, sometime back, who took ARC to a different level. And after that, believe me, Prashant has further. The beauty of Prashant's program is the consistency, and the way he takes this education so seriously. And each episode, believe me, sometimes I do hear those episodes as a listener, not as past president, but as a listener. But believe me, they are so good, so good. And the way he has penetrated, tier 1, tier 2, tier 3 cities everywhere. So very, very happy about the entire ARC team, and congratulations once again, and wish you all the best. And happy Guru Purnima to all of you.
Thank you,
Because
sir.
all of us are in different stages. All of us learn from each other. Even from youngsters also we learn. So happy learning, and congratulations once again.
Thank you.
Thank you.
Bye-bye.
Thank you. Bye.
Thank you, Lal sir, as well as Verma sir. Now, Dr. Tinku, before Dr. Tinku takes over, Dr. Anaga, one minute,
Yeah.
and then Tinku will
Thank you.
carry over.
Yeah. Thank you so much. And on the occasion of Guru Purnima, we have our humble pranams to all our mentors, all the seniors here. We have learned so much from each one of you. Thank you so much for guiding us, and we need your blessings. And I'm so happy that Dr. Prashant has been a great guide for us as a team member also of ARC. So thank you so much for everything to all our seniors. Thank you.
Thank you.
Thank you.
Dr. Tinku, now let us carry forward.
So first of all, thank you so much to all our teachers, Dr. Partha Biswas sir, Dr. Lalit Verma sir, Dr. Harbans Lal sir. It's been wonderful listening to your encouraging words. And with that, we are ready to begin this centennial session. Well, over the last 99 episodes, we've explored a rich array of formats. So be it case presentations or didactic lectures or investigative modalities. And it's only befitting that on our 100th episode, we explore the Journal Club. So the Journal Club is one of the cornerstones of academic medicine. And it is the journal articles, that help us to critically evaluate medical literature and to apply evidence-based knowledge into our practice. So I think it is a very, very important tool for the PGs to understand a journal and to critically evaluate it and to know which is the knowledge that needs to be filtered and applied to daily practice. So today we have two young postgraduates who will be walking us through two very important journal articles, and they'll be giving their insights regarding the limitations of these and the highlights of these journal articles. So to begin with, we have Dr. Silka Gupta, who's a resident doctor at the SMS Medical College, Jaipur. So these young presenters have been very ably mentored by their tutors. And Dr. Silka Gupta has been mentored by Dr. Rajesh Goyal, who's a professor at the SMS Medical College, Jaipur. So a very warm welcome to both of you. It's wonderful to have you, and we're looking forward to the presentation. We also have discussants who will be offering their insights and perspectives on the journal articles once the presenter finishes. And we have with us Dr. N.V. Prajana, who is the Academic Director of the Arvind Eye Care System, Madurai. We also have Dr. Rajesh Sinha and Dr. Praveen. They're still to join the program. So Dr. Rajesh Sinha is a professor of ophthalmology and professor in the cornea, lens, and refractive surgery services at the RP Center, AIMS. And Dr. Praveen Krishna is a cornea consultant, as well as the network director, technology and communication at the LV Prasad Eye Institute, Hyderabad. So a very big thanks to all these discussants. It's wonderful to have them here this evening. And with that, without much ado, I invite Dr. Silka Gupta to share her presentation, and we look forward to your journal article. It's an interesting topic, and the topic is topical insulin for refractory persistent corneal epithelial defects.
Thank you, ma'am.
So, Dr. Silka, please share your presentation.
Is it visible?
Yes, visible, Silka.
Good evening, everyone. I'm Dr. Silka Gupta, a third-year resident in SMS Medical College, and I'll be presenting a journal club on the topic Topical Insulin for Refractory Persistent Corneal Epithelial Defects under the guidance of Dr. Rajesh Goyal, sir. This is the abstract of my study. The topic of research is persistent epithelial defects. So, what are persistent epithelial defects? Any defect of more than equal to 2 mm square area lasting for more than 2 weeks despite the standard therapy is considered as a persistent epithelial defect. It's important because of its high prevalence of 6 to 10% in patients with the corneal diseases and accounts for a significant portion of referrals to a tertiary care center for a cornea specialist and its risk of vision loss. The common causes are limbal stem cell deficiency, infections, postocular surgery, trauma, exposure keratopathy. If untreated or resistant to therapy, they can lead to few complications such as corneal perforation, scarring, stromal melting, neovascularization, and severe reduction in the visual acuity. It can also lead to secondary infections. So why do we use topical insulin? Insulin and insulin-like growth factors, they are known to promote epithelial cell proliferation, migration, and adhesion, and play a key role in the corneal wound healing and signaling. So the animal models have shown accelerated healing with topical insulin, but still no large human studies have been done. So this study fills the gap. Our aims and objectives in this study were to evaluate the effectiveness of the topical insulin, to see the time required for the corneal reepithelialization after initiating the treatment, to assess the safety, tolerability, and the practical benefits, and to observe the changes in the epithelial defect size over time. Material and methods were the objective was to evaluate the efficacy of topical insulin in refractory PEDs. It was a prospective, non-randomized study conducted in San Carlos in Madrid. Topical insulin, 1 international unit per ml was prepared and was prescribed as 4 times a day. The follow-up time was till 3 months after the last patient that presented. The inclusion criteria was an adult patient with PEDs unresponsive to standard treatment over 2 weeks. Exclusion criteria were if there was an incomplete follow-up, if there was an absence of slit lamp images, and patients whose chart could not be reviewed. So the preparation of the insulin eye drops was done as follows. Regular insulin that was used subcutaneously was taken, that is 100 international unit per ml. It was diluted to 1 international unit per ml With a polyethylene glycol or a polypropylene glycol base, a sterile filtration was performed. It was packaged in a sterile amber glass dropper bottle and stored under refrigeration. It could be used up to 1 month after preparation. The pharmacist instructed the patients on usage and storage of the drops. These were the results. These are the etiologies that presented to us with persistent epithelial defects. A total 21 patients were taken with 12 females and 9 males, and the average age was 72.2 years. This is the time to start the treatment, the mean duration from the diagnosis to the topical insulin initiation. The baseline PED area was 17.6 mm square. Time to reepithelialization was about 34.8 days. And partial responders that did not show a complete healing had 91.5% reduction in the epithelial defect area. So 81% patients achieved a complete reepithelialization at the time of review, and the remaining 19% had a mean reduction in 91.5% reduction in PEDs at the review time. There were no adverse events noted. So these pictures show a patient. The first picture is the patient that presented after 16 days of topical treatment, and the subsequent images from picture B to G show the progression after the insulin drops were started. And the G and H pictures are at day 16 that shows complete healing of the epithelial defect. So other options are also there, like topical insulin. Autologous serum is also a good option, which shows a faster healing time of 22.4 days. But they have showed several advantages of topical insulin over autologous serum, such as its easier preparation, standardized concentration, cost effectiveness, longer shelf life. There is no risk of bloodborne infections, no interpatient variability. It is readily available and is well tolerated. Discussion. So the mechanism, as we have already discussed, is that the insulin stimulates epithelial proliferation, adhesion, and migration. It was effective in diabetics as well as non-diabetics both. It was the first large series evaluating insulin drops in the real-world setting. And the limitations of studies were that there was no control group. There were heterogeneous etiologies for the persistent epithelial defects. The sample size was quite small. Conclusion. The topical insulin is a safe, effective, and well-tolerated treatment for the refractory persistent epithelial defects. It significantly promotes corneal reepithelialization, even in the complex cases. It offers multiple advantages over the conventional options like autologous serum. And it also supports further trials and potential inclusion of the topical insulin to the standard treatment protocol for persistent epithelial defects. Thank you.
Thank you, Dr. Silka. I request Dr. Rajesh Goyal if he has any perspectives on this article, because Dr. Silka hasn't offered her perspectives, you simply. So,
Yeah,
Dr.
actually, ma'am,
Rajesh, if you could offer any, what do you feel about this article? Any
yes,
limitations?
yeah. Actually, thank you so much, ma'am. Actually, we are using autologous serum for persistent epithelial defects, and it is very good, 20% autologous serum. But we haven't used till now the topical insulin. But it is a very good thing. If it can be used, then it can be very helpful in case of PEDs. Because not all the patients can go through the AMGs and for the surgical procedures or transferopy. So, like we have gone to the ethical committee for this thing, topical insulin, and if they will permit it, then we will go for the research in this case. It will be very helpful to the patients. I think so.
Thank you. So, Dr. Prajana, sir, I would request you to offer your perspectives on this article, and do you think it has enough evidence for us to apply this to our clinical practice?
Yeah, first of all, I would like to congratulate Silka for a very, very nice presentation.
Thank you.
And we have to understand that it is not her study, and so we are not criticizing her when we talk about this study. So the only one thing as a postgraduate, when you evaluate any study, is to look at the inclusion criteria very, very carefully. when you really read a journal when you are a postgraduate, at least when I was a postgraduate, the first thing I will read is the aim, and the next thing I will read is the conclusion. And then that does not give you a perspective of knowledge. The first thing is to look at the inclusion criteria. You use the word refractory PED. So you should convince yourself whether they really did use it on refractory PEDs. Did they have a very good definition for what they called it as refractory PEDs? So what they're trying to say is they're trying to use this technique where nothing else works, right? That's the word refractory. But you have to convince yourself whether that terminology and the other treatment strategies were effectively employed. Do you really see in your reading, did you see any evidence for them to conclude that it was a refractory PED to start with?
Yes, sir, they were already using extensive lubrication and antibiotic drop. Like the standard treatment was already being given for at least 2 weeks, and still they were not responding. They have given a chart in the article.
Then that is very good. But you also mentioned in your conclusion that there was no control group, and that is very, very, very important because any study gets a much more better meaning when it is controlled with somebody else. It's like asking a question, are you intelligent? If that's a question that is asked to anybody, it all really, the right answer is it depends. If I compare myself to a 12th class student, I'm intelligent. But if I compare myself to Einstein, I might not be intelligent. So that is one thing which a randomized control study will give a much, much better option. And you rightly pointed out that there were many, many etiologies. And so this was one thing where it looked promising, but only an RCT could really give you a thing. Because in an RCT, one advantage is everything falls in place. The inclusion criteria falls in place. Both the groups will have similar types of patients, even though there are different etiologies.
Mhm.
And those things will have a meaning. But what do you think? Suppose if you are a postgraduate, one of the common cause of persistent epithelial defect is just injury with fingernails. Have you seen any case like that? You have seen, in this case, you have seen ulcers and other things, but have you seen any persistent epithelial defect due to fingernails or paper edges?
No, sir, not the persistent one. They
Okay.
usually heal.
Yeah, so those kind of things are a little bit different because they heal and then they break up. So that also is called as a persistent epithelial defect, where there's good migration, but then there is no inhibition. After that, there is no inhibition. After migration, what happens is this hyperplasia and then there's a breaking up. So it may be interesting to see whether they was that included in this kind of a study. But then I would also like to congratulate your team for exploring that. At present, your professor did mention that they're going to present it to the ethics committee for a formal approval. And I know that insulin topical applied is not a big worrisome factor with regard to systemic absorption or anything, because through the digestive system it's not going to work. But is that a concern at all?
So in this study, it was mentioned that it was given to diabetics and non-diabetics both, but there was no systemic effect, like any side effects were not noted, so it can be given in both the patients.
Yeah. So I think we're just discussing the principles of doing a study. The first thing is just don't do any harm. The second thing is have an effective control. The third thing is have a good definition for all the clinical condition to see whether it's this thing. But thank you and congratulations for doing a great job.
Thank you so much.
Dr. Silka, one quick question. So when they started the insulin drops, did this stop the other treatment modalities like lubricating drops, or did they continue?
Actually, it was not clearly mentioned in the study, but yeah, it was mentioned that earlier people were using, like the patients were using the extensive lubrication, antibiotics, and the other treatment. But then even BCL, they have mentioned that 62% patients were using BCL also. But then in this part, it was just giving that that insulin drops were started. So it's not specifically mentioned if they stopped the treatment or, yeah.
Okay.
I'm assuming they stopped it.
Okay. Thank you so much. With that, we move on. Thank you so much. I must compliment you on your presentation, and you
Thank
put
you so
forward something unique and innovative. But again, like Dr. Prajna said, every article needs to be critically evaluated and, before we can put it into actual practice. So with that, we move on to the second article for the evening, and that will be presented by Dr. Vaishna Megha. Dr. Vaishna is a DNB resident at the Comtrust Eye Hospital, Calicut, and she has been mentored by Dr. Arjun V, who is a consultant in the cornea and ocular surface services at the same hospital, that is the Comtrust Eye Hospital at Calicut. So welcome to both of you, and thank you so much for being here. So Dr. Vaishna again has a very, very useful article, that is low dose valcyclovir in herpes zoster ophthalmicus, the zoster eye study randomized clinical trial. So over to you, Dr. Vaishna, and looking forward to your presentation. Please share your presentation.
Just a second, madam. Madam, is it seen?
All
Yes.
good, doctor.
Yes.
Thank you. A very good evening to respected teachers, mentors, and colleagues. I'm Dr. Vaishna Megha, second year DNP resident, Comtrust Eye Hospital, and I'm mentored today by Dr. Arjun, consultant cornea and ocular surface. The article today I'm going to present is a low-dose valcyclovir in herpes zoster ophthalmicus, popularly known as ZETS, the zoster eye disease randomized clinical trial. Madam, 1 second. I'm having a problem. To minimize it. Okay.
Welcome, Dr. Praveen sir. Dr. Tinku, Dr. Praveen sir has also logged in. You can have him in the discussion as well.
Okay.
Hey, hi, good evening.
Doctor, just make it slideshow in slideshow mode and start.
Thanks for joining in. Looking forward.
Yeah, just click on the screen. You should be able to move the slides.
Yeah. Okay. So, low-dose valcyclovir in herpes zoster ophthalmicus, popularly known as the zoster eye disease, a randomized clinical trial, which was recently published in JAMA Ophthalmology with an impact factor of 9.2. The study chair was Dr. Elizabeth J. Cohen, and co-chair was Benny Jeng. The herpes zoster ophthalmicus, as we know, is due to reactivation of varicella zoster virus in the ophthalmic division of cranial nerve 5, which affects 10 to 20% of all the herpes zoster cases. It can lead to keratitis, uveitis, retinitis, scleritis, and glaucoma. The chronic and recurrent inflammation can cause scarring, vision loss, and decreased quality of life. The challenge is where patients often experience multiple episodes of recurrent inflammation, even after resolution of initial disease. The short-term antivirals are standard for acute management. They do not prevent recurrences. The study objective is to determine whether a suppressive valcyclovir therapy compared with placebo delays the occurrence of or new or worsening of stromal keratitis, endothelial keratitis, iritis, or dendriform epithelial keratitis during the 12 months of treatment, which was the primary outcome, and if this treatment benefit persisted for 18 months. That was the secondary outcome. Study adhered to the tenets of Declaration of Helsinki and was approved by the respective institutional review boards. A data safety monitoring committee was then appointed by National Eye Institute, and study was conducted under FDA approval. It was a multi-center, randomized, double-masked, placebo-controlled clinical trial with a duration starting from September 2017 till January 2023 with an 18-month follow-up, which ended on June 2024. Participants were followed up for 18 months, 12 months on medication, either with placebo or valcyclovir, and 6 months of treatment follow. Location were 95 sites, in US 85, 9 sites in Canada, and 1 site in New Zealand. It was a, okay. And study included immunocompetent adults of age more than 18 years with a history of typical herpes zoster ophthalmicus rash, a record of active keratitis or iritis within 1 year, who were able to give informed consent, and persons with a GFR of more than 45 ml per minute per 1.73 meter square. Study excluded the immunocompromised individuals and pregnant ladies. Randomization was done using an interactive web response system in 1:1 ratio, either with an oral valcyclovir of 1000 mg or a placebo daily with 12 months and follow up every 3 months until 18 months. Patients were randomized in 4 strata based on their age of onset, that is less than 60 years or more than 60 years, and disease duration at the time of enrollment, less than 6 months or more than 6 months, as we can see in this table. It was a double masked. That is, participants, investigators, coordinators, and leaders were masked. The coordinating center statistician was unmasked, who gave the data to the Data Safety Monitoring Committee. The endpoint analyzed or assessed were the recurrence of zoster eye disease, which included new or worsening eye disease, stromal keratitis, dendritic epithelial keratitis, endothelial keratitis, iritis, or stromal keratitis with ulcer. And the study was initially designed to estimate 30% risk reduction with a power of 90%, which would require a sample size of 1050. Being a long study, they had planned for an interim analysis in between, and significance factor alpha was adjusted to 0.049 with O'Brien-Fleming method. As due to slow enrollment, the statistical analysis plan for further revised in October 2020 to a sample size of 788 with 80% power. The final statistical analysis plan had to adjust for the temporary pause due to medication testing. And Kaplan-Meier curves to estimate the time to first occurrence of confirmed endpoint were plotted for the overall group and for each strata. Hazard ratio were estimated for measuring the treatment effect in valcyclovir and placebo group at 12 and 18 months. The overall significance of the treatment effect was assessed with stratified log rank test, and the subgroup assessed were using a stratified Cox proportional regression method. All the statistical analysis were conducted in R version 4.2.1. And this is a consort flow chart of the population study. We can see 651 individuals were initially assessed, 124 excluded as then they didn't meet the criteria. 527 were finally randomized, 266 treated with valcyclovir, and 261 with placebo. 35 discontinued the intervention and in the valcyclovir and 44 in the placebo group due to the following reasons. And 29 withdrew from the study in the valcyclovir arm and 38 in the placebo arm. As I already mentioned, 651 screened, 50.5 in the valcyclovir and 49.5 in the placebo. Being an intention to treat analysis, all these 527 participants were included. And coming to demographics, the mean age was 60 years with almost equal male and female, 50.5 and 49.5. And race and ethnicity, as we can already see in the pie chart, the majority, that is the 86.7% were white, followed by Asians, African Americans, Latino, Alaska Native, Pacificer, and other multiracial. So 93% were completing a follow-up of 12 months and 87% were completing a follow-up of 18 months. And 13%, as we have discussed in the consort, 13% withdrew from the treatment and 15% discontinued the study medication. The primary endpoint event, that is recurrence of the zoster eye disease, which included any new or worsening eye disease, was 33% in the placebo group and 28% in the valcyclovir group at 12 months, and 40% in the placebo group and 32% in the valcyclovir group at 18 months. The stromal keratitis was the most common primary endpoint, followed by iritis, epithelial keratitis, and endothelial keratitis. So this is a Kaplan-Meier estimate. We can see here showing the x-axis event-free probability and the y-axis time in months. The blue curve that we can see is the valcyclovir, the placebo arm. The blue curve is the valcyclovir arm, and the orange one is the placebo arm. We can see a slope of valcyclovir curve is higher than the placebo curve. That has a longer endpoint free survivals. And a stratified long rank test was done for overall, which at 12 months, the hazard ratio was 0.77 with p-value 0.09, which is not statistically significant. And at 18 months, the hazard ratio was 0.73 with a p-value of 0.03, which was statistically significant. This is the Kaplan-Meier that was done in the straight test, that is acute onset. Here we can see the A1 is less than 60 year and less than 6 months. B1 is more than 60 year but less than 6 months. So here also we can see the valcyclovir plot, that is the blue one is at a higher level, suggesting less number of endpoints over time compared to that of placebo, where the placebo's arm is steeper and lower. And similar is seen in the B group. Although that seems beneficial, but then on the analysis part, it was not significant. And chronic onset people, slopes were similar in both placebo and the valcyclovir. Coming to secondary endpoint analysis, Cochrane Q test was done to check whether the treatment effect differs across the 4 predefined strata, and the result was not no significant difference, suggesting the consistency of treatment effect across these subgroups. And a pre-specified subgroup analysis that is done for younger group, that is less than 60 years with a recent onset, less than 6 months. And at 12 months, the p-value was 0.06, and 18 months, the p-value was 0.08. So not statistically significant, but it did suggest a trend towards benefit, as we saw in the Kaplan-Meier curves. A post-hoc analysis was done, considering the previous trend noted in the Kaplan-Meier curves for the recent onset group. A post-hoc analysis was done combining the patient of less than 6 months of onset in all the age group. That is more than 60 years or less than 60 years, just the duration was taken. And in that early onset, at 12 months, the hazard ratio was 0.65 with a p-value of 0.03. And at 18 months, the hazard ratio was 0.64 with a p-value of 0.02. So patient enrolled, which was statistically significant. So patient enrolled less than 6 months post-zoster showed a greater potential benefit from valcyclovir group. And chronic onset group, the 12-month, it was 0.78 and 18-month 0.73, which was not significant. So suggests that the valcyclovir may benefit patients with recent onset herpes zoster onset, irrespective of their age. And coming to subsequent or recurrent endpoints, which is defined similarly to the primary endpoint that occurs after the first episode. And participants with more than 2 events were 7% at 12 months and 11% at 18 months. And in the chart, we can see that the recurrence is more in the placebo people than the valcyclovir group. The frailty model estimate was done to assess the multiple recurrence over time. And by 12th month, the p-value was 0.02. And 18 months also, p was 0.02, suggesting the valcyclovir significantly reduced the hazard of multiple recurrences compared with placebo at 12 and 18 months. Coming to compliance, measured using a proportion of pill returned at each follow-up, that is 3rd, 6th, and 12th. 2/3 of the patient had more than 80% compliance, similar in treatment and placebo group, including both males and females. The proportion in each group who permanently discontinued treatment in both the groups were also similar. Placebo 16% and 13% in valcyclovir. Safety outcomes, 50 participants of 527 had a GFR of 445 to 59, but the GFR values were followed up and there was no episode of acute kidney failure or reportable, suspected, expected, unexpected serious adverse reactions. Just in summary, the recent onset pre-specified one had a p-value of 0.06. It was not significant, but as we saw in the Kaplan-Meier, it had a trend toward benefit. And in the post-hoc analysis, the recent onset ones of 12 months and 18 months had a p-value of 0.03 and 0.02, which was significant. In the chronic onset, it was not significant. Limitations of the study. Study was underpowered due to an incomplete enrollment. The primary endpoint was not statistically significant. The exclusion of the immunocompromised individuals, dose or duration of antiviral was not optimized, and underrepresentation of Black patients. Conclusion, the primary endpoint of the study was not achieved, but not statistically significant. The secondary endpoint, though, the 18 months and multiple recurrence, was statistically significant. So valcyclovir reduced the multiple recurrence of keratitis or iritis. And subgroup insights, the patient with recent onset herpes zoster ophthalmicus showed the most benefit. When the recent onset were combined, the benefit was statistically and clinically meaningful at 12 and 18 months. Suppressive low-dose valcyclovir should be considered for ocular herpes zoster ophthalmicus, especially in a patient with multiple flare-ups. Final note, while not definitive for all the herpes zoster ophthalmicus, this trial do support a tailored approach favoring a suppressive therapy in recurrent or recent onset ocular involvement. Thank you.
Thank you, Dr. Vaishnav, for that very, very exhaustive article. And with that, I invite Dr. Arjun to give his perspectives of the article and, you know, what is his critical analysis of this journal article. Dr. Arjun.
Thank you to the ARC team and also Vaishnav. It was an exhaustive, well presented. We decided to take this study on two-pronged perspective, especially because on a cornea perspective, JETS is one of the most much awaited study in the past few years. And on a PG journal perspective, mostly we discuss studies which have clear outcomes and which have achieved the primary outcome. Though this is a well-planned, designed, funded study, it did not achieve the primary outcome and doesn't bring immediately a change in management in case of HZ2. But analyzing such a study for PGs and future researchers will give an overview of how to conduct a large study. What are the hurdles you come across doing a large study, and beyond the p-values, the investigators can come across newer protocols and generate new hypotheses for further research. Here you can see that the primary outcome did not show that it works, but in secondary outcome it shows it works, but that was never designed to be studied. So it's also an acknowledgement to the investigators who have planned over 14 years, that is 6 years of planning and 8 years of executing, to come up with the current evidence which they have transparently shown to the with the consort protocols. And this, I'm very fortunate that today we have stalwarts in our group who have done large studies, and they will be able to guide us how such a study is done and what are the difficulties we come across, and how this will help in future treatment protocols.
Thank you. Thank you. Thank you so much. So with that, we move on to the discussants. And before we begin, I'd like to welcome Dr. Praveen Krishna, who's just joined us. So Dr. Praveen Krishna Vadavali is the Network Director, Technology and Communications, and also the Director of the Shantilal Sangvi Cornea Institute and Institute of Excellence at the L.V. Prasad Eye Institute. He's also been a very, very enthusiastic teacher and mentor to so many young fellows. And it is indeed our good fortune to have us here to give his insights. So with that, I'd like to invite Dr. Praveen to give his perspectives on this article. Dr. Praveen?
Thanks a lot, Riku. I'm going to keep my video off because I'm still driving on my way. So first of all, thanks to Dr. Bhavan and the ARC for having me over as a discussant. And in addition to what Tinku just said, I also have the proud privilege to be a batchmate of Tinku's during my fellowship. So I think we learned and we probably did attend a lot of journal articles that were similar at that time. And the reason I say that is I reference the HEAD study, and though Tinku being a retina specialist will probably remember the number of times we discussed the HEAD study and the number of times they were presented during journal clubs about 20 years ago. And that's also because the HEAD study was very recent. And though I think it would be great to get Dr. Prajna's comments about creating and curating large studies, it is easy for us to sort of understand or point out the drawbacks of a study that is published in a journal article. But a multi-center study such as this, spread over several years, and especially for a disease that is not especially common, is a Herculean task to actually pull off. And so the very fact that they were able to even get more than 60% of the planned enrollment over the period of time, and they were able to get a significant amount of data, is actually, I think, quite an achievement for a study of this magnitude and of this significance as well. So the reason why this is important is not just from the disease perspective, but also is important from the economic perspective, because when you talk about vaccine for zoster, and vaccine for zoster is known to prevent adult zoster recurrences, but then again, it is not known to reduce the morbidity or the recurrences of zoster in the area of the eye or herpes zoster ophthalmicus. And so the cost of prophylaxis, both for insurance firms as well as for the government and entire society, including the patient, is quite significant if you don't have clarity about what you need to do. So from that perspective, this is still a very important study. Though it probably has not resulted in any significant outcomes and is probably not going to change practice patterns very much. Even studies that have a negative outcome, having saying that the hypothesis that they started with is not proven, are very valuable because that means that you don't have to do something that you assumed would work so far. So from that perspective, I think it is still quite valuable, very extensive and nicely presented as well. I just would like to point out one similarity between the HEADS, the herpetic eye disease study, and the Z study, and that was in the prophylaxis. In the HEAD study, for those of you who've read it, the last part of the HEAD study was about prophylaxis and reduction of the recurrences of herpes simplex. And as of now, to this day, oral acyclovir prophylaxis is the only drug that we have in our armamentarium to prevent recurrences of HSV disease in the eye. And the reduction of HSV when a patient was on prophylaxis was to the tune of almost a 50% difference in the reduction. Those who are on acyclovir had a risk of about 16% recurrence in the year that they were on acyclovir. Those who were not on acyclovir had a double that chance of recurrence. They had a 32% chance of recurrence. And so there was only a 50-fold reduction or a 50% reduction in the risk of recurrence. 100%. So it is significant. We follow the HEAD study and use the patients who are liable to get rejection, liable to get recurrences of HSV. But like that, the Z study sort of clearly shown that there is no significant advantage of using valacyclovir as a prophylaxis. I don't think we want to get into disease processes and all that discussion, but suffice to say that probably also because herpes simplex is because of a live virus infection, whereas herpes zoster is believed to be because of the vasculitis as well as the immunogenicity of the virus that is induced that actually causes recurrences, which is the reason why active drug may not prevent or reduce the recurrences in this scenario. So having said that, I think we probably can't take much back from the study except for the fact that we won't use valacyclovir for patients who've had herpes zoster, other than for those who probably, though this is not proved by the study, other than those who are potentially immunocompromised, because that is an exclusion criteria, and for those who have recurrent episodes of recurrences, and those are probably a small population that we'll deal with. So I'll stop there just as a quick summary of what I thought the study was about and what value the study derived. But again, well presented and well curated as well, Dr. Anand. And thank you, Dr. Tinku Bali.
Thank you, Praveen. You summed it up excellently and gave some very astute observations. So thank you so much for those inputs. Just a quick question: which is the drug that you use for treating herpes? You know, do you use valacyclovir or acyclovir? Just curious to know. Hello.
Yes, madam.
And Dr. Praveen.
Yeah, no, I think both acyclovir and valacyclovir are similar from the point of view of efficacy. They're the same kind of drug, same class, just that the bioavailability of valacyclovir is a little better, and also because the dosing schedule allows lesser number of frequent doses. So it doesn't matter what we're using. Eventually, the cost of both is the same as well. During the acute phase, I think all of us do know that the use of valacyclovir or acyclovir only tends to reduce the morbidity from the point of view of post-herpetic neuralgia. And now several internal medicine specialists also tend to give high doses of acyclovir or valacyclovir in the acute phase for the same reason. it doesn't seem to reduce the recurrence of the herpes zoster in the future, but to treat the acute episode. So what is traditionally used in textbooks, that is double the dose of acyclovir, 100 milligrams, 5 times a day for a couple of weeks during the acute episode, is what most internal medicine physicians use. And that's the same dose we use as well, but we do not use any prophylaxis for HZO as of now.
Thank you. Thank you so much. So with that, I invite Dr. Prajna sir for his observations and insights.
Thank you, Tinku. Actually, once again, I would like to congratulate both Megha and Arjun, and especially Arjun summed it very, very well when he made those points, and also Praveen had valid comments as well. So I'm just coming not for this study, but just for these two presentations. The first presentation had some positive message that topical insulin works. And the second study said the drug, valacyclovir, probably does not work. But if you just take the interpretation alone without understanding the nature of the study, then you might think that the first study had a good result and the second study did not. But I think most important thing in designing, in interpreting any study, is to look at the design of the study and to look at the conduct of the study. And in that way, the second study was much, much, much more powerfully crafted than the first study. And I think the second study gives us much, much more information, much, much more credible information than the first study. So I think that is the point I would like to drive across. And I have had experiences in doing large-scale RCTs. And one of the main learning which I have had was large-scale RCTs actually bring you down to ground level. You might think that this works. You would have tried 1 or 2 patients and work, but unless you do an RCT, you really cannot give a credible information to the general public. But the second thing which I really want to emphasize is the secondary endpoint, the primary endpoint thing. Usually when we design a study, we tend to take the primary endpoint because it usually gives us a sort of a question which will help us reduce the number of subjects to be enrolled to study. That is the trick. That is the thing which really helps, which anybody keeps in mind when they design the primary endpoints. But as you saw in this study, there were some things in the secondary outcomes which are of interest. And that is precisely how a study has to be taken. One thing leads to the other, and then we take it forward from there. So to just give one comment, for example, when we did the MUD study, the whole idea was we came out with the primary endpoint saying voriconazole and natamycin was similar or thing. But then if you really go into the depth of the study, you really understood that Fusarium and Aspergillus, the treatment is different. And for Fusarium, natamycin is significantly more important than voriconazole. I think that is the way you look at studies in general. And I think Megha and Arjun did a great job in bringing out all the facets of the study, the consort diagrams, the clear inclusion criteria, the clear exclusion criteria, primary outcomes, secondary outcomes, and what they interpreted in the study. And I completely agree with Praveen. A negative result is as important as a positive result. And so that means that we don't need to blanket treat everybody with this costly and not a very light medicine on all patients. And I think that is also a very, very important take-home message for the study. Thank you once again for this opportunity.
Thank you so much, sir. So we have just a minute or 2 left. So with that, I'm back to Dr. Praveen. So Dr. Praveen, before we end this episode, would you have certain pointers for our young postgraduates, when they sit down to read a journal articles, what should they be looking at? How should they be in their minds analyzing an article? Just a quick few pointers for them on how to analyze a journal article so that it's of use to them. Dr. Praveen? So I'll take the same question to Dr. Prajna, sir. Dr. Prajna, sir.
Yeah, so I think you please read the method section very, very importantly, and then interpret the conclusion with regard to that inclusion and exclusion criteria. So my suggestion to them is not to stop just reading the aim and the conclusion, but also read the methods. The methods is what counts. And that is how you should interpret. This road is long, long as opposed to what? Or this road is curved, curved as opposed to what? So I think that is the question which a curious postgraduate should be asking themselves. And that will be my only request to them, to read the method section as carefully as they read the conclusion and the aim section.
Thank you, sir. Thank you so much. Those have been some excellent inputs from you. So thank you for your presence here this evening. And with that, we come to the conclusion of this 100th episode. And I thank all the people who've been a part of this landmark episode. I thank Dr. Silka, Dr. Rajesh Goyal, Dr. Vaishna Megha, Dr. Arjun for their excellent presentations. You've really shared a wealth of information tonight. And I also thank our discussants, Dr. Prajna sir. Thank you so much for the time that you've spared to be with us. And Dr. Praveen, who was here with us giving his inputs. So with that, we come to the end of this episode. Thank you to all the viewers, also all the people who were there with us this evening. And just to let the postgraduates know that we have this episode every week. So next Thursday, we'll be back with another episode where we'll be exploring another topic. It could be a case presentation, an investigative modality, or just a didactic lecture. So please watch out for these PG teaching episodes every Thursday from 8 to 9. So with that, I bid you all a very warm goodbye, and thank you so much. Good night.
Thank you, Eric.
Good night. Well done. Very well done.